So LFP, just to put it in perspective for you, has three components. One component is the physician gets paid for their time.
Mhm.
The other component is that the physician gets paid for the encounter.
Okay.
So when the patients come in, and then the third component is they also get paid for complexity, like the complexity of their patients. And
Mhm.
currently, our complexity fees and how it actually gets
Mhm.
recognized is not adequately
Mhm.
adequate, and it's not inclusive of all our patients. So currently, we're using a system that really just recognizes complexity as someone that only has diabetes, kidney disease, um, COPD, which is chronic bronchitis,
Mhm.
liver disease, and cardiovascular and neurodegenerative disease. So what that means, it's excluding patients that have cancer, so they have cancer care. It's excluding everybody that has mental health,
Mhm.
so that
Right.
massive mental health component, substance abuse, chronic pain,
Mhm.
women's health, all of that is excluded in terms of complexity. Those complexities are not being remunerated and recognized for the time that they're spent. They're getting the same pay seeing a mental health patient as someone that's just coming in and getting their ward zapped, which, as you know, is not the same work. So that needs to be clarified. Also, a lot of new generation physicians now um, are not wanting to be kind of stuck to a
Mhm.
cohort of patients for as long as they are in their career. And I think one of the biggest things we can do for them is to make them feel like they're being supported. So that you maybe share a practice with another physician, or the clinic takes ownership of the physicians or of the patient themselves, or the patients are attached to the clinic, but there are certain physicians in charge of the cohort of patients. And I think currently you can't do that with the LFP model. In fact, when you share a practice, you actually don't get remunerated because your complexity doesn't get picked up by two physicians. LFP is currently only working for longitudinal care,
Mhm.
who also then does, and we've expanded it to maternity care, to nursing home care,
Mhm.
to sort of hospital facility care.
Yes.
But if you have a sort of a specialty niche practice, and you're not doing longitudinal care, LFP doesn't work. Now we've kind of stopped the bleeding from longitudinal family physicians leaving, but we've also created burdens on the system by not having enough walk-in doctors, not having enough hospitalists, not having so you can't fix one system and forget about the rest. Everything has a trickle effect on every change you make, and I think that's what we need our Ministry of Health to really sort of embrace. And changes can happen simultaneously, so that one change doesn't have an ill effect on the other.